Welcome back to Meet the Experts, and we are back in the United States of America. We are going up to upstate New York to meet Diana Mason. Diana, welcome to the show.
Thank you, Casey. It's really nice to be here. Where were you before coming back to the United States?
We were teeter-tottering around somewhere in, where were we? In Africa? I think we were in Africa.
And where in Africa?
We were in Nigeria, Africa.
So, yeah. I direct, I'm the program director for the International Council of Nurses Global Nursing Leadership Institute. It's a policy leadership institute we only take about 30 to 35 nurse leaders a year. We almost always have nurses from Nigeria, and we've had some outstanding ones recently, and we've really been getting larger cohorts of nurses from the African continent. So this is all good.
Well, this is going to be a really good conversation. Hold on to your chairs. We're going to rapid fire ask Diana Mason some questions. But first of all, let me tell you, she is the OG of nursing. How long have you been a nurse, Diana?
I've been a nurse for 45 years.
Wow. That's
55. 55. I'm older than I look.
You look great. I cannot believe you've been a nurse for 55 years, but I do feel so privileged and honored to talk to you because I'm sure you've seen nursing change a lot since you've practiced.
A lot.
Yeah.
When I started, my first job was in the Army Nurse Corps. They paid the last 2 years of my school, and then I had to go in for 3 years afterwards. I was not a very good military person, but I can remember I was working intensive care, and I remember sitting in this nurse's station. We were smoking and drinking supersized Coca-Colas to stay, get caffeinated. So things have changed. I'm no longer drinking, and for me too, I'm no longer drinking sodas, and I have been nicotine-free since 1987. So, yeah.
That's amazing. But look how far we've come, and we have a lot longer to go. But before we start talking about the future, we want to get to know you a little bit. Are you ready for some rapid fire questions?
We'll see. I am older, and how rapid I can be, we'll see.
Okay, no problem. Okay, so my first question to you is, if you could share one piece of advice with your younger self, what would it be and why?
It would probably be trust yourself and know that you can do it. And I think it's because as women, we often grow up questioning ourselves. We live with the imposter syndrome more so than men do. There are a number of times when on my career path, I was going one way, and then I took a detour because I thought I guess I should do this. But my heart wasn't there, and I ended up spending time to come back. And so I think trusting where your heart is, what your passions are, and trusting yourself that, it's a rigorous career. It's a rigorous education program. It's not for the faint of heart, but it is something that, you can do. You just have to persevere.
I love it. Thank you. So next question. If you had the power to change or transform one major aspect of healthcare, what would it be, and how do you envision it impacting the system or the people that it serves?
Well, I'm going to give you two. One is I would have a national health plan. I would have a single payer system. Yes. When you go to other countries, as you probably know, and you have to use their healthcare, those countries that have those single payer systems, boy, it is so much easier than our system. Our system is chaotic, and we keep trying to patch things in, and it's not working. But the main thing I would do is say we need to shift funds from acute care to primary care. We do not have a robust primary care system in this country. In 1946, Congress passed the Hill-Burton Act that built out hospitals in this country after World War II. All the advances in medical science during the war, the advances that we make always during wartime in terms of how to treat injuries and wounds, etc. What we learned then, we realized, wow, we could really ramp up what we're doing in acute care in the United States if we invested in building out hospitals across the country and expanding existing ones. So the Hill-Burton Act provided funds for hospitals for acute care in return for those hospitals providing some semblance of free care to people in need. That program is done. But we need a Hill-Burton Act for primary care, because as a result of the Hill-Burton Act, we didn't pay attention to primary care. And so we really have to build out a system where we're focusing on how to do health promotion and prevention, how to do early diagnosis and treatment, how to coordinate care, and how to teach people to self-manage their care as much as possible. So I sit on the board of, I'm actually the secretary now of the board for the Primary Care Development Corporation, which is a CDFI, a community development financial institution, a nonprofit, the only one in the country that's devoted solely to building primary care capacity in this country. And so we give low interest loans for building the buildings. We do advocacy work around policy, and we do work around consulting to help build better practices. And one of the pieces of advocacy that we do is around just getting states and the country to track how much we spend on primary care. We do not track that everywhere. And so we know we probably spend about only 5 to maybe 8% of all healthcare dollars on primary care, even though you get so much more bang for your buck in primary care. You can actually reduce healthcare costs overall and improve health in a major way. So we're really advocating for states to start requiring that all payers track primary care spending, and gradually the payers increase the amount they are spending on primary care, or the percentage of their healthcare dollars spent on primary care, until they reach at least 12%. So there are a few states that have already done that. I'm in New York. We're still trying to get this through New York. And we'll keep pursuing it because we have to do this. I'm not a nurse practitioner. People think I'm a nurse practitioner because I'm such an advocate for primary care. I am not. You don't have to be to recognize that we must have a robust primary care system in this country. And we have federally qualified health centers throughout the country that really are well suited to providing the kinds of comprehensive care that you need in primary care that combines mental health, behavioral health, social needs care, as well as the usual primary care. So I feel very strongly about this.
Well, I am very passionate because this is very much needed here in the United States. Question for you: someone's listening, and maybe they're a nurse practitioner, or maybe they're a healthcare administrator, and they're like, I want to do this in my community. How do they get in contact with your organization?
It's pcdc.org. It stands for Primary Care Development Corporation, pcdc.org. I'm also happy to talk to any nurse about this and to particularly if they're interested in advocating for primary care and trying to get this tracking and increasing of spending on primary care. And I'm happy for you to share my email with people.
Absolutely. My follow-up question, I know you're not a nurse practitioner, but what role do you see nurse practitioners fitting in this role of increased primary care?
Oh, I think they're essential because physicians aren't going into primary care because it doesn't pay them enough. I have some concerns about we have a lot of programs preparing nurse practitioners, and I'm not sure of the quality of all of those programs, and we've got to pay attention to that. So it used to be that early on, the nurse practitioners were really experienced nurses with 20 and 25 years of experience. So they knew what they were doing anyway before they got there. They had more of a skill set by going through programs. Initially, they were certificate programs, then master's programs, and now DMP programs. But we've got some people who go straight through, and I know there are advocates for that, and we that's fine. But then what are we doing to make sure that that nurse has the skills necessary to be able to hit the ground running? We have residency programs, but you go to a rural area like I'm in, the hospital here, the practice here cannot afford to have somebody go into a residency program. There just aren't the resources to do it. So I think we have to pay attention to the quality of the nurse practitioner, but I also want to encourage RNs. So I co-chaired with a wonderful physician, Tom Bodenheimer, a report that was sponsored by the Josiah Macy Foundation. And this was back in 2015, and it was using RNs to transform primary care. So that if you have an RN, that RN can be really the point person for me as a patient, calling me ahead of the visit. Tell me why you're coming in. When I come in, I see that RN first. They do the history. They do what's important to me, blah, blah. And then when the nurse practitioner or physician assistant walks in the room, that nurse is reporting out with me there. And the primary care provider, the NP, is then able to say, okay, this seems like we need to do this and this and this. They get my agreement as the patient on it, and they get the RN's input on it, and then the RN helps to carry out that plan and can even do follow-up calls and care coordination, et cetera. Sure. But many nurses, they want to make more money that the hospitals can pay, because most primary care practices pay more money, don't pay as much money.
I was going to say, usually when you have nurse practitioners in a community setting like that, they're working more with the LPNs because the community centers can't afford the RN. But do you see space if we had more billable services for nursing? Do you see more space for nurse entrepreneurs to get in there and actually create these care management services that work along with the nurse practitioner?
Yes, absolutely. Now, whether it's as a separate business or not, I won't comment on. I'm not sure. But there are some practices. There's a fabulous nurse practitioner and head of a fabulous network of FQHCs, federally qualified health centers in Connecticut. Her name is Margaret Flinter. She's been around a long time, and she's really thoughtful about how she uses RNs. They use them for care coordination and for some other functions. But there's some other places that really have developed nurse-led, nurse-run health centers, and often with a nurse practitioner and an RN. So I think there's a lot of room there for innovation. My concern is that what's going on is there is an upskilling of medical assistants to be able to do more, which is fine, but it's like, why are we not paying attention to the skill set that the RN brings in patient teaching, in counseling, in that care coordination? So I think we need to do some research, some health services research, looking comparatively at what happens when you have an RN in these roles versus another provider. And if the data don't support it, then that's fine. But I'm not sure we have made the case that RNs are not really value added.
And I think I'm just going to say it. I may get flashback for it, but not all RNs are created equally.
Yes.
Of wide variety. And I don't say that to mean that some are lower than others, but you have RNs that are really great with skills. Maybe whatever technical skills you need, any adjustment of equipment, tools, anything, they can do it. But they may not be as strong on the education side, on the care planning, on the case management. So when we use RN, it's blanket, but each RN brings such a different skill set.
And Casey, a lot of nursing programs don't give RN students the experience in primary care.
Yeah.
So that's really something that schools need to address, and it's one of the things that we recommended in the Josiah Macy report. There is some evidence out there that if you have RNs working to the top of their education and training, even associate degree RNs working to the top of their education and training in this model that I described, that it really does not cost more. You have better outcomes and everybody has joy in practice because you've got the nurse practitioner or family physician or physician assistant practicing to the top of their education and training, doing what nobody else can do. And everybody's, really, really up their game, which is what I think we have to do.
I think with the shortages coming up, we won't have a choice but to do.
Yeah.
My next question for you is, in your experience, what is one skill or mindset that most often prevents nurses from reaching true success in their careers?
I think it's mistakenly believing that being political means keeping your mouth shut. And that instead we need to think strategically about how we communicate. I feel very strongly about this. A colleague of mine, Barbara Glickstein, and I do work on strategic communications. We do media training, but the broader concept is strategic communications. It's not just how do you do good communications, it's how do you think about, here's my issue, here's my target audience, and here's how I need to frame this issue for their values, beliefs, and priorities. And it may be how I frame it will be different from one person or organization to the next. Mm-hmm. And so I think we need to be more strategic and not feel like being political means keeping your mouth shut. We don't need more wallflowers. We need people who are willing to be bold and take thoughtful, calculated risks. And it goes back, I think, to some extent to the imposter syndrome. Mm-hmm. And if you're finding yourself feeling that, checking yourself and saying, wait a minute, what am I feeling here and where's that coming from? So I think the more that we can, I also want to say that I think nursing education has to look at how to do a better job of preparing RNs to do this strategic communication and to use their voices thoughtfully and boldly. I know it's hard when you're inexperienced and you're just learning the ropes, but somehow we need to start instilling that in people, I think.
So as a nurse of 55 years, I want the comment section to be humming because I would love to hear what the audience has to say. When we're talking about strategic communication and you talk about political, and nursing is very political. Nursing is very political. Healthcare is political. So many nurses have experienced, especially back in the day, when they tried to vote, they would be penalized for being verbal and outspoken. And so many nurses, when you think about the archetype of a nurse is usually caring for more than just their family. Some of them are carrying communities on their backs. Yes. When you talk about nurses from different countries, they're caring for people in maybe multiple family members. So to see when they are outspoken, to see them penalized and maybe, losing their career. I've had another nurse, she was on the board, and just to see how sometimes we're coming from a culture where if you're not on the same agenda, you could be really blackballed in this. Yes. How does the younger nurse navigate this? How do they assert their leadership skills without being rude and disrespectful, but still making their point and standing firm to their beliefs, values, and identity as a nurse?
Well, let me say that being rude and disrespectful never has a place in strategic communications, as far as I'm concerned. It just doesn't. I I also think I have a lot of confidence in the younger generation. I don't think they will come from the same place. Um, so I have a book, Policy and Politics in Nursing and Healthcare. And the first edition was, I think, in 1983, maybe, or 85. And I wrote a chapter in that edition of the book, and maybe two editions, called The Politics of Patient Care, and argued that everything we're doing is political, because politics is about, allocating scarce resources. So how you use your time. And I gave an example in there, in that chapter, of my brother had a brain tumor, and he had the surgery. And when I came in to see him after the surgery was done, and I think it was the first day he was out on the regular floor, and they were going to put an NG tube in him because he was having a hard time swallowing. Well, the surgery affected his swallowing. And so instead of somebody taking the time to pay attention to what his diet was, what kind of, like a Jell-O, rather than, even liquids at that point, and how to swallow, and sort of tilting his head at the time. I don't know if this is still current practice, but tilting his head to the unaffected side. Mm-hmm. That, and really being patient with him. They were going to put an NG tube in him. That's a choice. That's a political decision. It's saying we don't have the time to spend to do something that is less intervening and is going to help him in his recovery, because I don't feel like I have the time because staffing is short. Yeah. All right. And now we're saying, well, you don't have enough time in the hospital because of payment system. So all of this is political. Mm-hmm. And I used to hear nurses say, well, I don't. So I was also the editor of the American Journal of Nursing. And whenever I would write an editorial about, the importance of being politically savvy, I would get letters from nurses saying, we shouldn't be, nursing is not political. I don't want a chief nurse officer who's political. And I would not want a chief nurse officer who was not very politically astute. I want a chief nurse officer who's going to think very strategically about how to get what he or she needs for the care of patients, for making sure that nurses are there in adequate numbers, as well as other healthcare workers. So I think we have to change our mindset about what political means. Mm-hmm. And to me, it really is about being strategic. And if people aren't comfortable with the word political, I would say, think about strategic. Do you not want to have somebody at the helm who's very strategic in how they're approaching issues? And that means we're thinking about how to develop a plan on something in which we will be successful.
Now you're talking about policy and politics. Question for you, and be real with us. Do you think there are enough nurses or enough people in the position where they are at the table and actually advocating for the nurse?
No, except I would say, so when I'm on the board of the Primary Care Development Corporation, I will and have brought up, when they talk about primary care physicians, I'll say it's primary care providers. Other people are in this space. Let's change our language. Mm-hmm. That's not the first thing out of my mouth. I'm there as a nurse, but I'm not there to just advocate for nursing. Mm-hmm. I'm there to advocate for primary care. So I would argue that we need to be at more decision-making tables. And when we're there, we have to have the big picture. We can't just come with special interests. I want to promote nursing to promote the health of people. So we have to keep in mind, nobody really cares about nurses and nursing. What they care about is their own health and the health of their families and their communities. So you've got to frame your issue within that context. Yeah.
Very wise words. I started off in the community, attending the local government meetings, the city council, and I said, who's looking out? I was thinking maybe the health department. They said, no, the health department's not here. Well, who's looking out for the health of the community? No one. And then I thought I was crazy, and I showed up enough times and everybody just looked at me weird. And then I found out another city in Florida, they actually brought a nurse to sit, the community, the city council brought a nurse so that she is there just to look out for the health of the community. And I'm like, to me, that's a no-brainer. Who's looking out for our community?
So you should run for that city council. Yes.
So I had a friend, she was actually in the running, and so I was supporting her.
Good.
But I don't think it's a really strategic position, and people think that the politics in healthcare has to do with the politics in the world, in the country. But we're looking out for the humanity of each citizen. It doesn't matter what their political affiliation is.
Yeah.
Anyway.
So two resources for your listeners. One is the Nurses on Boards Coalition. If you just Google it, they have opportunities for nurses to serve on all kinds of boards. Yes, you can go to try to get onto get elected to the board of a nursing organization, but you're staying in the nursing silo, and get your chops built, get your skill set built up on those boards, but then branch out to non-nursing groups. So Nurses on Boards Coalition is a great place to get resources about, how to get on boards, what do you do when you're on a board, et cetera. And that work arose from the first Future of Nursing report, and I was pleased to have a hand in that. And then the other resource is Healing Politics. So if there's a listener who's interested in running for office or being a campaign manager for a nurse to run for office, Healing Politics has been developed by two nurses who are now have a training program, a campaign. It's like a training ground. You go to campaign school, and they have a newsletter and other webinars, et cetera. So if you Google Healing Politics, and that it should come up. So those are two resources that people might want to think about with this.
I absolutely love it. I'm just going to broaden out a little bit because we have viewers from all around the world. And I'm just thinking about if they're looking and because they are just as passionate as we are to make changes in healthcare. What you have happening in a lot of different countries is where the younger generations they're wanting change. The older generations, they don't want to let control up. So Diana, as part of the International Council for Nurses leadership team, where you're actually bringing in these leaders from different countries, what would you say to that young leader who is looking for a way to express themselves and really make a change in their country for nursing?
I say keep at it. And I will tell you that those of us who are older need to step aside and open doors for that next generation. And I do that all the time. I don't need, I've done it. I've been there. I've done that. I don't need to do all the things that I'm asked to do. I can open doors for other people to do it. And that's my responsibility to do that. And around the world, there are nurses. I know nurses in Africa who are pushing back on some of the older nurses who are the old guard and they don't want to change. And a nurse I know in the Caribbean who was really struggling to really own her power and to really, make a difference in her country. And it was the older nurses who were saying, no, you're too young for that one. No, she wasn't. So the message for older nurses is wake up, pay attention. We've got to support these other generations of nurses who are coming behind us. Do whatever you can to say, yes, try it. I'm here to help you. I'm here to say, okay, if it didn't work, and back you. We need people to take the risk and to step up. And for the younger nurses, just don't give up. Find a mentor. And say to your mentor, a mentor who has some cachet with the older nurses, and say, I need you to mentor me. And part of that mentoring is I want you to open doors and help me overcome some of these barriers. And that nurse from the Caribbean, she's soaring.
Awesome. I love it. You know I'm from the Caribbean, so that is
Oh, good.
my heart.
Where?
Glad I am a Trini to the bone. I love my Caribbean nurses. I love my Caribbean people. And I see that. I see that
Yeah.
really echoing. You know what I would say too, because what I am building is an international network, a global movement where we are moving in a different spirit, where they can even network with leaders in different countries and borrow the research of what's working in different countries to use it in their own systems. So as we build this global momentum, I definitely think having experienced nurses like yourself, saying it out loud, now they could take it back and say, here is this nurse. This is what she's saying. Let us, they have the backing. They have our backing.
Yeah. Yeah. Yep.
Now, I did have one final question for you. Florence, and it's in line with what we're talking about. Florence Nightingale, she envisioned a future nursing revolution that would be 200 years from her time, which lands us to today. What do you think it will take for nurses to re-evolve the position and practice of nursing?
I'm not sure I understand the question.
So Florence Nightingale, she one woman there were a lot of nurses who really impacted nursing.
Right.
We have our nursing theorists, but Florence Nightingale, she stands as the mother of modern nursing. When she was on her deathbed, she said about 200 years from her time, there would be another movement, much like what she did, where our profession of nursing
I
is
think
going
we've done it. I think we've done it. And I think what it is the advanced practice nurses and our cadre of nurse scientists. I think we have a wonderful, and it's another concern I have, that the DMP programs have overtaken the PhD programs. And there are some people who really want to do research. And if you want to do research, if you want to be that nurse scientist, go get the PhD. That's the research degree. And so, but I feel like we have some fabulous nurse scientists in this country and now in the world. I mean, you go to Taiwan and they're doing serious research in Taiwan. You go to other parts of the world and Australia, the research is quite serious. So I think she would be very proud of this cadre of nurse scientists who are doing really important work that was getting funded by NIH before the recent changes in the leadership in the United States. It was getting funded. They were doing important work. And so I think that, and the fact that we've got these doctorally prepared clinicians as advanced practice nurses who are looking not just at the individual patient, but at population health. So I think she would be very proud of where nursing is at today in the United States. But because of your global perspective, Casey, I would say one of the responsibilities we have right now is to look at how we can elevate nursing in all countries. Yes. And ICN, I'm a consultant with them. I'm not on staff with them, but ICN's had a major focus on getting countries to recognize there is a business case for countries to invest in nursing. That if you invest in nursing, you're investing in women often, but not always. You're investing in a family and you're investing in a community. And they've even done some analyses of the return on investment, that for every dollar you invest in nursing, you are generating this much in revenue or savings. So, and that report is out there that you can Google and find. So I think encouraging for us to encourage a global investment in the nursing workforce is what we should be doing to make Florence proud. And Mary Seacole.
And Mary Seacole. Yes. Oh, our beautiful pioneers, nurse pioneers. And I think they have paved the way for us. And now we have to take it and run into the future. It was such a pleasure talking to you. Now, audience, I asked Diana all of my questions, and she has been so kind and patient to really answer them. But I know you have questions. I know this conversation may have sparked. Maybe you agree, maybe you don't agree. Let's hear your thoughts. Leave it in the comments below. If you want to get involved in any of the cohorts or the leadership that Diana is doing with all of her different enterprises, connect with her on LinkedIn. She would be happy to help you. I am so glad that you took the time to be here with us today, Diana. I'm so grateful for your time.
Well,
And
it's been my pleasure, Casey, and particularly with a Trinidadian.
Trini here. Well, you know what? I think we are going to do some amazing things together. I look forward. Maybe we will have you back again to answer all the audience questions.
Okay, my pleasure.
So, thank you. We will see you next time. Stay tuned to our next episode of Meet the Expert. Thank you for tuning in.